All right, thank you very much. I'm Josh Spiegel. I'm going to be presenting an interesting case of vague abdominal pain that came in about 3 weeks ago. So first, I'd like to thank Dr. Burns and Dr. Giles for allowing me to participate in the residency program here. I'd like to thank Dr. Barker, Dr. Bell, and Dr. Hyde for letting me participate in this case, and the rest of the faculty, staff, residents, and students for all your help this past 2.5 months so far. I have no disclosures related to this case. So today we're going to first go through our interesting case and go through the operation that's associated with some short history and the pathophysiology of the disease process, and then a literature review of that. Okay, so BN is a 58-year-old female. She has a past medical history of fibromyalgia, osteoarthritis, obesity, anxiety, depression, and chronic back pain. She's never had surgery before. She's on some SSRIs, some pain medication. At home, she has only seasonal allergies, and she denies tobacco, alcohol, or drug use, and her family history is not contributory. So for her, she came in and presented to Erlanger North. She's been having left lower quadrant pain for about 2 years on and off. This pain increased over the past week or so, and her friends, she was at her friend's house, and her friend said that she needed to go to the ER, so she obliged and went to Erlanger North. When she got to Erlanger North, they did some labs, which were pretty benign, normal LFTs, only that she had some hyponatremia to 130. There they did a CT scan of her abdomen, and at that point they transferred her to Erlanger, Maine. Additionally, when she got here, she had one episode of emesis and continued abdominal pain. We were consulted around 2 a.m. overnight. When we got down to the emergency room, she was afebrile, blood pressure to 144/75. She had a regular rate and rhythm, and breathing at 18 respirations per minute with 99% on room air. She's an obese patient with a BMI of 39. When we saw her, she was in moderate distress, and she was diaphoretic. Other pertinent physical exam findings: her abdominal exam was soft, tender to palpation in the left lower quadrant, and there was no palpable hernia, no umbilical hernia, inguinal hernias, or any other hernias noted. Looking at the CT scan, we'll go through it real quick. Starting out to look pretty benign, and then if you notice in the left lower quadrant, she has a hernia here. Noted here in this slide, you can see a clear delineation of dilated bowel, and then coming back of a decompressed bowel after, so a clear obstruction there. Additionally, to be noted is the position of the hernia itself. Here you can notice that the hernia is actually in between the external oblique muscle and the internal oblique muscle, and here the transversalis here and rectus abdominis here. Okay, so what's next? So with her physical exam findings and her imaging, we diagnosed a small bowel obstruction secondary to a hernia. Specifically, this hernia is what's called a Spigelian hernia. And I'll go into that a little bit later, but for her, we made her MPO, we placed an NG tube and gave her IV fluids, and she was consented for surgery. So the operation itself, first we made a 1.5 centimeter midline incision in the epigastrum with dissection and entrance through Hassan's fascia. We had adequate pneumoperitoneum, and then a laparoscope was placed, and this is what we found. So first we came in and we thought we saw something. We went a little bit further, and then we found the hernia itself there. So as you can see, this is the anterior abdominal wall, and then you have small bowel coming up and herniating through the abdominal wall. As of note, this was an incarcerated hernia, and additionally, we inspected the rest of the abdomen, and no other abnormalities were found. Laparoscopically, we pulled down the bowel out of the hernia sac and inspected it here. So this is the extracted small bowel after takedown, and we were able to see visual peristalsis, and the bowel appeared viable and non-ischemic. This is a picture of the hernia site after the bowel was taken down, and then we proceeded to dissect out the hernia sac, and this is an image of the completed inverted hernia sac. This was then ligated using electrocautery and scissors. After this was completed, a small incision was made over the hernia site, and a suture passer was used to pass 3 number 1 Ethibond sutures on each side of the fascial defect for closure. And then the peritoneum was then closed using a running V-lock suture. And this is an image of the peritoneum after repair. And then at this point, the incarcerated bowel was re-examined and still found to be viable and peristalsing, and then finally all the skin incisions were closed using forovical suture. So Spigelian hernias in general, they actually have a very interesting history. They were first described back in the early 1600s by this man, Adrian van den Spiegel of Denmark. He was a very famous anatomist at the time, and interesting, this description was actually published 2 years after his death in this paper that he wrote, De Humani Corporis Fabric Libri Tabulis Aere Incisus Exornati. Other fun facts about him, he actually gave the first comprehensive description of malaria. He has multiple anatomic structures named after him, including the semilunar line, which is also known as the Spigelian line, the Spigelian fascia, and the caudate lobe is also known as Spiegel's lobe and named after him. Additionally, he has an entire genus named after him, genus Spigelia, which includes, for example, a woodland pink root, which is used for treatment of intestinal parasites. So brief anatomy review. Spigelian hernias are classically described as a protrusion of the peritoneal fat, peritoneal sac, or organs through a congenital or acquired defect in the Spigelian aponeurosis. So this is a picture of the abdominal wall above and below the arcuate line. So above the arcuate line, you have your oblique muscles, internal, external, and transversalis muscles coming in, forming both the anterior and posterior abdominal sheaths. Below the arcuate line, all of the muscle tendons come and form the anterior abdominal sheath, but there's a lack of a posterior abdominal sheath. The semilunar line here and here is the lateral border of where Spigelian hernias can go through, and the Spigelian fascia is this fascia between the oblique muscles and the rectus muscle. And this is the area where the Spigelian hernias herniate through. Classically, they present here, either at the arcuate line or below the arcuate line. Additionally, 20% of them present as incarcerated hernias, and they're usually very small, only 1 to 2 centimeters in size. They present in patients between their 30s and 60s, and the incidence is between 0.1 and 2% of the population, and they encompass less than 1% of all hernias. So this is an image of a Spigelian hernia going through the Spigelian fascia, medial to the oblique muscles and lateral to the rectus muscle. Additionally, this is where the Spigelian hernia lays. It goes through the transversalis and internal oblique fascia, the Spigelian fascia, and actually does not go through the external oblique fascia there. Many of these patients have their Spigelian hernias diagnosed by CT because of the need for a very high level of suspicion to diagnose these hernias. Usually they're asymptomatic and they're non-palpable. Every once in a while you will be able to palpate a Spigelian hernia, but due to the common comorbidities of these patients and most of them being towards the obese side, it's usually you're usually unable to palpate these hernias. They present usually with abdominal pain and sometimes bowel obstructions. The best and most reliable imaging modality is ultrasound to diagnose these hernias, but like I was saying, most of them you need a very high level of suspicion, and these patients usually have CT scans prior because they're not specifically looking for the Spigelian hernia at first. So differential diagnosis for this, because of its high level of suspicion, you need kind of pretty much look for any hernia, as well as bowel ischemia. They can present as bowel ischemia. Also, they have been confused with acute appendicitis and anterior cutaneous nerve entrapment syndrome. It's very common for these patients to be misdiagnosed, and they also I also found a case report that showed that a patient was first diagnosed with diverticulitis and taken to the operating room, and then they found out once in the operating room that the patient actually only had a Spigelian hernia. So what do we do for these patients? There's two different ways to repair these hernias, either an open repair or laparoscopic repair, and there's a decent amount of literature describing both, more so the open repair, and Polestina et al. Actually found no difference in outcomes between the open and laparoscopic repair when they did their 28 patient case review. For an open repair, you would do a transverse incision and go directly over the mass. You would try to locate this either by palpating it or using imaging to locate the hernia. Additionally, you would split the external oblique fascia to expose the sac. And then you would close using by approximating the medial to lateral edges of the internal oblique and transversalis aponeuroses. Additionally, mesh is not required for these repairs, but is sometimes used. For laparoscopic repair, you want to place your trocar sites to maximize your exposure and working space, reduce the hernia, and then repair the defect. So when do we use mesh? The literature I could find specifically for Spigelian hernias recommended that in Spigelian hernias less than 2 to 3 centimeters, you would do a primary repair, and anything larger than that, you would use mesh. So next, I'd like to go over a case report or a case series where they described a specific technique for repairing these hernias laparoscopically. Over at Michigan State University, they used what they coined the scroll technique. This publication described 8 case series spanning from 2002 to 2006 under one surgeon performing all the laparoscopic Spigelian hernia repairs using this scroll technique with mesh repair. Additionally, they performed a literature review on top of this that supported their argument for laparoscopic repair. Of the 8 patients, the average age was 47 years old. Mean weight was 96.7 kilograms. Mean BMI was 32. And patients' hernias were 6 of the patients' hernias were on the left side, and 2 of them were on the right. 7 of the hernias were below the umbilicus, and 1 was above the umbilicus. Additionally, the mean operative time was 92 minutes, and the average size of the hernia was 8 centimeters squared. So for the scroll technique, you would take your piece of mesh and first put stay sutures on each side of the mesh as so here in the 4 corners, here, here, and here. Then you would roll up the mesh in a scroll fashion, leaving 2 of the stay sutures exposed, and then rolling the mesh up, and then adding additional sutures to keep the scrolls in place. This mesh would then be inserted through a trocar site into the abdomen, and using a suture passer would take the exposed stay sutures and secure them to the abdominal wall transfascially. The goal of this was to have 3 to 5 centimeter coverage of mesh past the edge of the defect circumferentially. And then next, the first suture holding the rolled leaflet, such as here, would be released, and the first leaflet would be unraveled. The suture passer was then used to take that originally non-exposed stay suture and make that transfascially, and then use tacks to tack up the rest of the mesh. This would be done again on the other side as well, completing the hernia repair. Additionally, this paper reported no complications for any of these 8 patients with a mean follow-up time of 32 months. Lastly, I wanted to go over the cost of the difference in repairs. The piece of mesh that they used in the Michigan State series was this mesh here, and that the average size of their repair was 8 centimeters squared, and a roughly 8 centimeters piece of mesh costs about $345, while what we used was we used 3 Ethibond sutures costing $21 and 1 V-lock suture costing only $25. These are all my references, and I'd be happy to take any questions.
Questions, comments? Yeah, Dr. Dart.
So, Josh, what do you think in this particular patient? Just, I mean, this is sort of guess, but what do you think the recurrence rate of that repair is going to be?
I'm not sure of a specific rate. I think that the way that we repaired it and the size of the hernia itself, the literature suggests that it will not recur. I think that our transfascial repair, we got good bites on the fascia itself, and since it was a true Spigelian hernia, the aponeurosis itself and semilunar line is pretty stable. So I don't believe that she will recur. If anything, it would be due to her obesity and reduced strength of her abdominal wall.
BMI was 40?
Yeah, 39, yeah.
Yeah, so, I mean, statistically, there's probably a greater than 50% chance it's going to recur, regardless of how you fix it, just in her. And I personally think that somebody's going to fix this again at some point, just as big as she is, and just putting 3 sutures across it.
Yeah, I think so too. I had that written down in my notes, the first thing to say. I really appreciate the fact, though, Josh did something in his presentation that when you're presenting cases in the future about the vital signs, I think it really is interesting to present the BMI because we increasingly are aware that obesity has an effect on both disease and surgical outcomes, but it sure would have a difference in a case like this. For example, if she had an umbilical hernia, instead of this, same size, would you have just closed it with sutures?
Probably not.
No. I mean, you can close it, and the recurrence rate with that is 80% plus. And with a BMI of 39, it's probably 90%. So I'm like Dr. Dart. I think the chances of this hernia recurring are better than 50%. So write her name down keep it somewhere so when she shows up in the emergency room, somebody take her in pretty quick. Now, was she had a virgin abdomen. She had not had previous.
That's correct.
Okay, all right. So for the student's benefit, she had a partial small bowel obstruction. So virgin abdomen, small bowel obstruction, patient needs an operation. Because there's always some cause for it that, or almost always, there's some cause that you can correct surgically. So I thought that was an interesting point of her history too. Dr. Maxwell?
Yeah, I'll jump on the bandwagon, kind of make it a Thursday morning case out of a Wednesday morning case in the future here. I just wanted to add, though, that I think this kind of standard that is emerging with hernia repairs, if you can get primary fascial closure and then put a piece of mesh on it, that's the way to go. And you were almost there. I mean, it would have been nice if you pulled the peritoneum down.
A piece of mesh on top of that.
Just tack a piece of mesh to the fascia and then close the peritoneum over it, and you had a really nice result there.
I do think closing the fascia is a good idea. I don't like you. I mean, I prefer that as opposed to just sticking a piece of mesh on there, because then you get a balloon of the mesh effect, and seroma incidence and so forth is much higher if you just put the mesh in. But I'm like you. I mean, you're sitting there looking at it. It would have really been easy to stick just a 5 by 5 centimeters, 6 by 6 centimeters, get a couple of overlap. It would have been easy. Dr. Child?
Start by saying very nice presentation by both of you guys. Another place you can see this, and I've seen it twice, is spine exposures, where they go on the retroperitoneal plane, and then the retractors can sometimes disrupt that spigalian fascia area. So I've fixed two like that looked just like this when they came in. And both of them actually were missed by the radiologist on the CT. The patients came in, they got sent because they were having recurrent symptoms and nobody could figure out what was going on. And you could clearly see it on the CT, just kind of going right through that muscle plane. Just to go back to the mesh issue, was it discussed just based on the fact that she had bowel that looked, not as healthy as you would expect, at least on what I saw? I mean, it looked like there was maybe a little bit of ischemia there.
That was the initial, and then when we went back after the repair to look back at it, it looked almost normal. Yeah, it pinked up very well.
I think that's a legitimate point. I mean, you've got valve that may have been somewhat ischemic in there, and I'm not saying it's necessarily the wrong decision. I mean, sometimes you make this, you just with recognizing that it's probably going to come back at some point. I mean, I've been there before where I was like, I'm just not going to put a piece of mesh in this stuff that's got all this old nasty blood that has had some bowel that was marginal in there, because you really worry about, I mean, the last thing you want is a piece of infected mesh in there. But I do think that you got to recognize that this is probably not. And then the other option, if you do that, is that you close the peritoneum at this point and just make an incision over the top of it and put an onlay on top of it of mesh, and that's a described technique. So
I wasn't there, but I'd have put the mesh in anyway. I don't think that'd matter. But I mean, I understand your concern. I just think I probably would have. And like we say, we're turning this into a Thursday case instead of a Wednesday case, but everybody has an opinion.
Well, I have a different slant on it here, and that is nobody has talked about the direction in which the incision was closed. If you look at the lines of tension on the skin, if you close that incision transversely, the fascia that is, you're less likely to get the tension that woman's putting on her abdominal wall every single minute of every single day. Now, if she stands up, yes, you do get some more superior, inferior tension, but most of the time the obese patients are getting more lateral tension on their fascia. So if you close that transversely, you might gain yourself a little bit of ground in it not recurring.
Absolutely. Same thing is true for all incisions. I mean, a vertical incision has 47 times more tension on it than the transverse or subcostal incision does. If you look that up in the literature, somebody analyzed it and put it all together about 30, 40 years ago with strain gauges and what have you to figure that out. And so that's the reason the incidence of recurrence is so much higher in a vertical incision than it is in a transverse or subcostal incision. Dr. Clements and I had gotten to where toward the end, the last 10 years of our career, we did very few vertical incisions, almost all of them transverse or subcostal, because you just never had an incisional hernia to speak of. So that was a very good point. All right, any other questions or comments? Two very nice presentations. Thank you very much.
Thank you very much.